Okay, perfect. So malignant hyperthermia, this is like one of the emergent situations that we learn about in anesthesia school. But it's not just concentrated in the OR because it can happen in the PACU, and then you can even see it later on in the ICU or the floor. So it's important for all of us to be aware. And especially if you have crash intubation that you need to do, you'll kind of need to know about this. So it affects us all. So I like to do case presentations. So a 10-year-old presents to the emergency room with acute appendicitis. They're scheduling them for a lap appy. Because this is a full stomach, we intubate them with succinylcholine. And when after they push the succinylcholine, they notice that their masseter muscle, which is your jaw, is rigid. And then on the screen, this is your end tidal waveform. Usually it should stay the same height on everything, but they see that it's going up like this, and that means the number for the end tidal is rising too. And then tachycardia also occurs. Despite trying to change the vent settings to get the end tidal CO2, and maybe it's pain medicine, or pain, that's why the heart rate's going up, they both continue to rise. And learning from pre-op, this is their first anesthetic, so we don't have any previous history to go from. And so at this point, with all this information, we assume malignant hyperthermia, and we call for help. We call this disorder malignant hyperthermia, and notice that I did not say anything about the temperature yet, so remember that. So the pathophysiology for MH is it's an autosomal inherited disorder. It's dominant. And the two triggering drugs are succinylcholine, which is a paralytic that was used to intubate, and volatile anesthetics. Those are our anesthesia gases. So this is isoflurane, this is desflurane, and sevoflurane. There's other ones, halothane, and some other ones that we don't really use in the U.S. anymore. But these are the main drugs that will cause an MH crisis. So it's a defect in the skeletal muscle gene ranitidine receptor. So RYR1 is the specific ranitidine receptor. So this is a skeletal muscle cell. So here's your ranitidine. Sorry, I have a cold. Sarcoplasmic reticulum. What do you guys remember from school? What does that function in the cell? What does that do? Anybody remember? So the SR houses calcium. So it releases it when a drug or other circumstances are needed. So from when an MH episode occurs, the SR releases calcium through this RYR1, the ranitidine receptor, and goes out through the tubule. So there's an excess amount of calcium. Tons and tons and tons of calcium are released. So that causes the muscles just to contract. That's why that patient had muscle rigidity, and then the rest of their body was going to end up generalized rigidity. So the sustained contraction, just think about if you're working out and you have the sustained contraction for quite a while, it's going to create a hypermetabolic state. This is a very common term associated with MH. So you're unable to get rid of all that CO2 because your muscles are working so hard. The O2 consumption goes up, so your supply goes down, and you can't regulate your body temperature later. So manifestations. Early, you're going to see that muscle rigidity, the masseter muscle, the jaw muscle that I mentioned when they intubate, profuse swelling, increased expired end tidal CO2, breathing really fast, high heart rate, and arrhythmias. So late. So even though this is called malignant hyperthermia, increased temperature is a late sign, not an early sign. Because your muscles are spitting out all these toxins, you're going to get an elevated creatinine phosphokinase, that's the CK right there, and myoglobin levels, another byproduct from the muscles. Your urine's going to be dark, so you'll have some myoglobinuria, rhabdomyolysis, acidosis, your potassium goes sky high, and if you just sit and wait on this, you will have heart failure and death. So a little bit one of the complicating factors is the high potassium and the myoglobin. So this crazy picture of pathophysiology just kind of shows that. So here's your sarcoplasmic reticulum. Use all your ATP, which is energy. Do you remember that from school? Use all your energy up. So you're going to increase your CO2, your lactate. Actin myosin filaments are just the muscle fibers. So all this energy, all your good energy, your ATP is just used up, and so that's why you get the increased CO2, lactate, heat. And so the sustained muscle contraction, the calcium release, heat, all release, and using up the ATP cause cells to die. Do you guys have any experience giving blood? So old blood is higher, this is a side note, has a lot of potassium in it because as cells start to lyse, the potassium build up. So kind of just a side note, but kind of a correlation. Whenever you have high potassium, you can get arrhythmias. You probably know that if somebody were to push potassium way too fast somewhere away. And then the myoglobin buildup from causes damage to the kidneys. So this is kind of like a multi-system failure will happen. So it's inherited, autosomal dominant, like we spoke. In kids, it occurs more often, so that affects us more. 1 in 25,000 carries the gene. It's across every ethnic group, every country. And then in the U.S., we have about 600 cases reported per year. There's some hot spots: Wisconsin, Michigan, West Virginia, and Nebraska. So, you know, there's probably more people who have it walking around, but of these surgeries, this is what we see. We just had a lecture on the new drug that came out to treat this, and there's probably 15 of us in the room and only one who actually might have had a case of it. They kind of caught it early. So it's very, very rare, but when it happens, we have to act quickly. So this is also interesting. It may not happen on the first anesthetics. They could have a normal, fine first anesthetic, and then their second or third one down the road, they could end up having this develop. So that's important. And then it may occur in the recovery room or after up on the floor or ICU. So even one of the precautionary measures that we can do if we have a patient who we're suspecting has a history, say the mother had an MH carrier and whatnot, but we don't know about the patient, we'll just treat them as an MH patient, and then in recovery room, we won't even put him in the normal recovery room. It's a very open environment. We'll put him in a separate room because all the other patients who are breathing off their gas, that could cause an MH episode. So they could be very, very susceptible to this. So we kind of try to treat them as MH. Does that make sense? So some of the susceptible disorders to being a carrier for this, anything that affects your skeletal muscles or the ranitidine gene, especially your dystrophies and myotonias. So central core disease, King-Denenborough syndrome, I mean, these are very, very rare syndromes. But if they have these, we treat them as MH precautions. Duchenne's and Becker's muscular dystrophy, it's not a true MH, but we avoid succinylcholine because they can have some of those bad side effects that go along with it. So initial management, we can't just sit around, we have to act quickly because this is going to get worse very fast. So the immediate thing is to discontinue the triggering agent. If we gave succinylcholine, we're not going to give any more, so you can't really do anything about that. But if they're on gas, we turn off the gas completely and switch them to a different agent like propofol, something that does not trigger MH, but they still need to get rid of all that gas. So declare it an emergency. Don't act like you can handle this on your own. You're going to need lots and lots of help to get this taken care of. You want to hyperventilate because remember that CO2 is just rising, 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 rising. So you want to just hyperventilate them to get that CO2 to come back down. And you're going to want to place them on 100% oxygen. High flows. The higher the flows are, the faster that it'll get rid of that gas. There's two treatments. They're both the same drug, but they're formulated a little different. Up until 2014, we only had dantrolene. And then in 2014, they created a drug called Ranadex. We'll talk about that. If there's arrhythmias starting to occur, we're going to have to treat those, and cooling the patient. So give me some ideas. How are we going to cool this patient? Speak loud. Ice packs, good. What else? Say it again. Cooling blanket, good. What about your IV solution? Yeah, you can get some cold IV solution. Yeah, cold ice packs, IV solution are all good ways to do it. And then the MH hotline. So the MH hotline runs 24 hours a day. There should be some information cards at the bedside. At least we have them in our carts. It's just 800 MH Hyper. And when you call this hotline, it's a national organization that will walk you through exactly step by step. You'll be on the phone with them the entire time. They go through, okay, what have you done? They'll tell you exactly what you need to do from there. So it's a really, really good resource, and if it occurs, you have to report it to them too. So MH carts, there's MH carts throughout the hospital. We have them in the OR. The ED has them.
We have one in the OR in our Center for. Anyone, if you ever needed it, it's available. The other one is now in radiology. It used to be in the ED, but it's between radiology and the ED.
Huh.
It's between, if you go down to radiology, it's between a CT scan and an MRI.
Oh. Oh, cool. Good.
Okay, well, that's good that you see it. But remember, we also have one in the Center for.
Okay, perfect. So it kind of looks like this. There's a refrigerator in there for your cold IV solution that we talked about. Because they're going into an acidotic state, there's bicarb on there. Dantrolene, there's sterile water without bacteriostatic agent in it. So we'll talk about why that is very important. And then insulin and D50, and we'll talk about that in a minute. Yeah, they just did that like a month ago, I think, which is a good thing. So I don't know if I talk about that again. So insulin and D50. So why do you think this is on the cart? Do you remember? This is kind of a more advanced. Yeah. So what is insulin? Which insulin or D50 or both? What does that do to the potassium? How does it work? So insulin drives the potassium into the cell. This is kind of like that 3 sodium in, 2 potassium out. So this is the sodium-potassium pump. And so the insulin helps that. Why do you think the D50 is on the cart? Yeah, exactly. So you don't want to go hypoglycemic on you, so because you're going to give a large dose of that. So good. All right, so there's 2 drugs. They're both dantrolene sodium is the generic name. There's Dantrium and Ranadex. They both work the exact same way. They're skeletal muscle relaxants. Remember, we were contracting, so now we want to relax. And when it was contracting, it was releasing tons and tons of calcium, so this drug will inhibit that. So the difference between the two is with Dantrium, it was a 20 milligram vial right here, and you have to reconstitute with 60 mLs of sterile water. That's why that is on the cart. It cannot be mixed with anything else. It will not completely dissolve. So this is what you need to reconstitute it with. And so I read that you need to be in a facility to properly treat this. You need 36 vials of this. Whereas Ranadex, you only need 1 vial, sometimes 2. So can you imagine how much help you're going to need getting the 60 mLs of sterile water in these vials? Everybody's mixing it. It's like molasses to mix it. It's really hard. I've never done it, but that's what everybody says. And it's really hard, and you're trying to get it to dilute. So 36 vials. They're going to need a lot of people helping you out. And this, if you ever, there's going to be places that don't buy this. So if you ever go to another place, then you have to do this. You have to shake it till it's clear. Whereas Ranadex, it turns orange. So if you're shaking it up and you're like, whoa, why is this orange? It's because the Ranadex is supposed to be orange.
Very expensive. Some places won't. Well, we didn't switch out until just recently because ours was expiring.
Mm-hmm.
And you can understand it.
Yes. Yeah, no, that's fine. So dantrolene, again, calling the MH hotline, they'll help you, but I'm sure there's a card on that cart that tells you exactly how much, but it's 2.5 milligrams per kilogram, IV push up to 10 milligrams for this one. Just keep on repeating, and you're going to be pushing lots of vials until the end tidal CO2, heart rate, and muscle rigidity starts to subside. And then once the crisis is under control, they'll be sent upstairs, intubated on a dantrolene drip. So the Ranadex, it's 250 milligrams. You reconstitute with 5 mLs of sterile water. Again, sterile water on both cards, both drugs. So the one vial we talked about. So if you have greater than 100 kilos, which we get those in peds, then you'll need 2 vials. But most of our kids will get away with 1. So it saves a lot of time, manpower. You can get their therapeutic level a lot faster with just 1 vial versus, needing tons of vials. And the maximum cumulative dose is 10 milligrams per kilo. So post-operative management, they're going to go to the ICU and they're going to be intubated. We've got to get that CO2 down. We're not going to pull that tube until that CO2 is at a normal level. What kind of lines do you expect or want to be in? Arterial line, why? Good. Yeah, you're going to need to draw lots and lots of labs. So we want an arterial line so we can get those blood gases. What else? They're going to have myoglobin urea, so Foley. Foley would be good to measure that. What about IVs? Some large bore, couple, at least 18 gauges. This patient's going to be really sick, so we want some good lines in there. So probably be giving some bicarb. We talked about the calcium. What is acceptable? Less than 38 degrees Celsius. So I read that even these patients can get up to greater than 110 degrees Fahrenheit. So they're going to be hot, sweating. So it's going to take them a while to get cooled until that muscle metabolism slows down. I talked about the drips, and then we're going to start giving some diuretics too at some point to prevent all those byproducts, the myoglobinemia for the renal. It can cause renal damage, so we want to try to diurese them and get all those metabolites out. So what kind of teaching do you want to do on the floor? This patient just had that, you want to just send them home and say, okay, bye, you had a great day, or what do you want to tell them about their future anesthesia and surgeries? Yes. Yes, they should. They should have, and what drugs should you tell them that they're not allowed to have? And inhalational anesthetics. So they'll have a different kind of anesthesia every time they come in. Good. So they'll get a skeletal muscle biopsy, but the important part of this is that it's not definitive. Even if it's negative, we're going to still treat them as MH. Say they have a parent or somebody in their close family has it, then we'll always treat them as MH. I think it said 20% of the muscle biopsies I read can be false negative, so if there's some family history, we're going to treat them as MH. So how do we screen or prevent these patients? We can ask certain kind of probing questions preoperatively. Has anybody in the family had problems with the anesthesia in the past? Did anybody have a really high temperature or need ice packs with surgery? Sometimes people will tell you, oh, it took me a while to wake up or whatnot, but if somebody had a history of MH, they would be able to tell you based on your patient education. In the OR, we usually keep patients asleep with gas, but we're not going to be able to with these kinds of patients. So we do what's called a TIVA, total IV anesthesia, and that's just basically a propofol drip and sometimes remifentanil, whatever, depending on what kind of case it is. But we will avoid the gases completely. We will not intubate them with succinylcholine. And also we'll put on these things. They're called charcoal filters on the anesthesia machine, so that if there was any residual particles of the gas just still lingering around in the machine, these charcoal filters will impede that from getting to the patient. So They're really good. They're really expensive, but it also saves time too, because before we had these, we had to flush the machine for like 30 minutes, and we're holding up the OR and whatnot. So this is really good. Somebody told me that they put these on the machine, and then they decided they weren't going to treat the patient as MH. And they turned on the gas, and they're like, why isn't this patient going to sleep? They completely forgot that these were on there. So it is a true test that if those are on, no gas is getting to the patient. And then they should be in single rooms, like we talked about before. They shouldn't be sharing a room with somebody else who just came up from PACU, because blowing off that gas, they could end up having an MH episode. All right, so let's go through down each one of these. Which one is not a triggering agent? Is morphine? Succinylcholine? Nitrous oxide? No, correct. Propofol? Isoflurane? Rocuronium? Sevoflurane? Versed? Ketamine? Desflurane? Dilaudid? Fentanyl. Good. Questions? So it's important to know, I want you to take home that it could happen later for you. Most of the time it's going to happen in the OR, but it could happen for you later. Act quickly, get help, no succinylcholine, no gases. Good? All right. Good. Sorry, I'm sick and so like, ugh. Yeah, just trying to talk and. All right. Anything else? Yeah, are you gonna go over the image? I wasn't sure if we were gonna like talk about.